My talk was 10 Commandments of a Successful UK. So, as he alluded to, there are various options, metal back, all poly, mobile bearing, and so on. And these are some radiological representations of the same. So why consider uni? The advantages are low morbidity and rapid recovery. No, you don't need to dislocate the patella. There's no issues with the cord's recovery, the lower costs, and the subsequent revisions as and when needed is relatively simple. So the first thing, and again, I acknowledge what Mohan mentioned, this is the single most important consideration criteria. So the commandment number one is patient selection. You need to have minimal deformities. It must be degenerative in its etiology. There should be no subluxation. And body weight is no restriction, and more recent articles have actually alluded to the fact that even patients with BMI of 40 are indicative of successful uni. Again, the deformity needs to be correctable, and you need to have bone-on-bone pathology with a lateral intact cartilage on the lateral side. So these are the second and the third. I think it's also important to understand what are the contraindications. Any inflammatory arthritis, flexion deformity, or varus valgus deformities beyond 10 degrees. In the young patient, in ACL deficiency, and when there is a lateral tibial thrust, and you've already heard about the lateral changes on the patella. Some amount of lateral changes are acceptable. These are extended indications and do not interfere with the outcomes. Again, Mohan did my talk some good in terms of radiological evaluation of a true lateral view of the knee, and he's already alluded to this arc sign. I think the other important factor is uni is not a surgery that should be undertaken by the occasional surgeon. You need to do at least 20 per year, or rather 20% of the total volume. So it's not something that you just pick up and go ahead and do. These are some facts from a Claessen's article in 2022. And you can see that there are very few surgeons who actually do this volume. And that's really what that accounts for the poorer results. And when we looked at the New Zealand, the UK, and the Australian registry, less than 5% of the arthroplasty surgeons used less than 1% of these procedures. The next indication is you undercorrect the deformity. It's important to understand that you do not do soft tissue releases, and you leave your knee 2 millimeter lax and extension and 90 degrees of flexion. Oftentimes, an arthroplasty surgeon looks at a uni as a similar procedure. And it's important to understand that a uni is not half a total knee replacement. Can you move this? It's not going ahead. The other thing is to understand about the tibial slope, because this is very important, and sometimes reducing the anterior tibial slope, particularly in the bone morphology that you see in this part of the world, will take a deeper cut anteriorly and the same cut posteriorly, and will equalize the flexion and extension gap. This is the typical example of this patient. You can see this patient has 15 degrees of posterior slope, and in this case, reducing the slope will give you a snug fit, and it tightens the gap. The next thing is to understand the angulation of the femoral condyle. There's a diversion angle of almost about 18 degrees, and you need to reproduce, and you need not to reproduce this, but actually put your femoral condyle at right angles to the resected tibial surface. And this is really the vertical orientation of the femoral block. So this is the 7th criteria for a successful surgery. A typical example of a postoperative X-ray which looks undercorrected is an ideal correction, and the one on your right is overcorrected, though the components actually look very well aligned. This is more in line with a total knee replacement philosophy. These are some schematic step-by-step using a measured resection technique using the Persona system. And this allows for good visualization. You need a very small incision. You do not need to dislocate the patella. So the key issues is place the femoral component at right angles to the long axis of the resected tibia, protect the ACL when making the sagittal cut, and this is very, very important, and avoid making a varus tibial cut with resection of minimal tibial bone. Some of the newer designs actually have these screws that actually prevent your sagittal saw from going through. And this is a very new introduction in this new Persona partial knee system. You also need to prevent the stress rise at the proximal part of the femoral surface, and this will prevent impingement with the patella. You need to leave the knee in 2 millimeters of laxity on the varus side. This will align with the philosophy of undercorrecting and reproducing the pre-arthritic anatomy of the knee joint. What not to do, I think it's also important. These are some surgical errors. These are all our own cases that we got for revisions. Critically, you don't want to be doing that for sure. Sagittal cuts going too deep, leading to fractures. These are sequential fractures, should be avoided. Osteoarthritis progresses over time and leads to polyethylene wear. These are some of the timelines. And this is the mother of all surgeries, where the femur was put back to front. I call this affectionately the unus invertus. And revisions are relatively simple. You can get away with primary surgeries, primary implants. Rarely, when there is a profound bone loss on the medial side, you need to address that. We have also been doing bi-uni replacements of late, and this is an excellent alternative to a total knee replacement for the right indications. So these are some of the newer trends that we have been embarking on. A quick snapshot of literature. Way back in 2005, Rich Berger from Chicago spoke about 13-year survivorship of 95%. Seb here has written extensively on unis, and in his younger under 50, the main indication or concerns were polyethylene wear. So bi-uni is not really a substitute for total knees, but in selected indications, younger patients, it functions at least as well as TK. In terms of survivorship, four higher risk of revisions with mobile bearing. So if you are using a lateral, it's preferable to use a fixed bearing. In terms of the survivorship and risk factors for revision, the main factors are male sex, younger age, diabetes, and cementless fixation. And in terms of robotics, one of the things that I certainly subscribe to is robotics is the one solid indication for using technology in robotics. So this is one of the recent articles, particularly for the lateral side, which showed no differences between mid to long-term follow-up. Thank you for your attention.